There's a secret world just outside the hospital walls where clinicians trade stethoscopes for startups. If you've ever wondered how someone goes from seeing patients to building the future of healthcare, you're in the right place. I'm Kayla, a PA on a mission to figure out what comes next. When I started researching careers in health tech, I found confusing job titles and zero clarity on how clinicians actually made the transition. So I went straight to the source, the people who already did it. Each week, we demystify a specific career path by someone who's already living it, whether it's from the bedside to the boardroom, the startup, or something completely different. Whether you're planning your exit, passively curious, or already working in health tech, this is your insider's guide. Welcome to corporate espionage. And today, I'm really thrilled to welcome Erin Kreider. She is a nurse practitioner and former ICU nurse who leaned into solving the problems of revenue cycle, coding, and utilization management. She made the unconventional leap from bedside care to becoming the CDI and product lead at Ambience Healthcare, one of the fastest growing mission-driven companies in healthcare. She's a published journal author, award-winning leader, and she's still practicing as an NP while she's tackling one of healthcare's biggest headaches, helping providers spend less time clicking boxes and spend more time with patients. So I am really excited to talk to you today, Erin. I certainly do not know as much as I want to know and understand about CDI and so I'm really excited for learning from you. Welcome to the show.
Thank you so much for having me, and I'm excited to give a voice to CDI and to AI and help kind of define some of these more complicated healthcare adjacent roles.
Yeah. So let's dive right in. So everyone has a story. I'm curious to learn more from you. You started your professional career as a nurse at the direct bedside. So can you give us a little bit of insight into why you wanted to be a nurse, what kind of nursing you did, and more kind of into that journey?
Yeah. I went into nursing because I wanted to help people. My grandpa was a physician, and I saw how much of his life was invested in his role. And so I kind of leaned into the nursing role because I also saw that you don't get to spend as much time with your patients. I chose critical care because I enjoyed some of the more challenging and engaging type of roles in that setting, but quickly realized that nursing, bedside nursing, while I enjoyed it, there was so much to it that burnt me out very, very quickly. And so even into like 3 years into my career, I had worked CV-ICU and med-surg ICU. I began to kind of investigate. Well, when I was in nursing school, everybody told me that you can do so much with nursing. So I kind of started to investigate what exactly that meant and learned a lot about roles adjacent to the bedside setting that really complemented and helped you keep a lot of your clinical thought and skills, but not so much with the burnout and the hourly rounding and the documentation requirements and a lot of the administrative things that come with nursing that take your time away from patients and actually making an impact for your patients. So that's kind of where that started, and how it kind of evolved to me leaving the bedside.
When you were going through that exploration journey, did it feel more like you were looking for opportunities because you were moving towards that, or did you feel like you were getting pushed away from nursing for the negative things?
Um, I would say it was a combination. Everyone who knew me, who worked at the bedside, knew I was very, and still to this day, I put 100% of my heart into what I do. And so when I feel like I can't accomplish and put out this high quality, um, best, best impact type of work, that follows, rules, that follows best practices, that actually gets to research and incorporate best practices into my work. I think I was on the receiving end of a lot of that burnout, which kind of inspired me to it. But once I recognized and learned and did a lot of individual study on things like case management, utilization management, and CDI, that's kind of where I drifted and recognized that I could probably invest my passion and still accomplish what I loved about nursing, but maybe without a little bit of the direct care burnout requirements that some people don't, you know, get burned out by. But when you're somebody who gives 1,000% of your soul, at the end of a 12-hour shift, it's extremely exhausting. So that's where I kind of gravitated. And luckily, I had an opportunity at a younger age in my career than I think is traditional when it comes to those types of roles to explore that opportunity. And once I got my foot in, I really developed my passion for that because I could see how it impacted patients beyond just a 12-hour shift.
So many of us can probably resonate with having the heart to give 1,000% and just feeling totally drained of that empathy and capacity to give at the end of a long day. I certainly resonate with that myself. I'm curious, you said that you were like given the opportunity or had the opportunity to lean into one of these roles. What happened there?
So I found a smaller hospital that was local to me that was just starting a CDI program. They
Mm,
had this was in 2010, 2011 when CDI was actually a relatively newer um evolution with the MS-DRG system and how we got reimbursed as hospital systems and how the documentation was impacted also in that transitional phase of EHRs.
right.
So where what was good in documentation and codable at one point, there's now all these new requirements that kind of come with that technology advancement. So it was at a very new point and opportunity, and we had two very senior staff that had started the department, but they were looking for somebody who had the critical care experience and also brought kind of a fresh perspective, maybe less of the bias that comes with the more experience you have, you can kind of get jaded and biased. So they were looking for that kind of fresh mindset,
Okay.
and so that's how that opportunity really evolved for me. And we started the program kind of all together. So it became what we wanted it to be in a lot of ways, obviously under the guidance and overarching responsibilities from our accrediting bodies like AHIMA and ACTIS and what our company wanted. But yeah, we were able to kind of make it our own new thing. So
I love that one of your assets in that situation was that you weren't so cynical to not do a great job.
yes, yeah, that's probably that's a good way to phrase it.
That's how I hear what you said.
Yeah, yeah. I mean, you get jaded and you get used to certain things going a certain way. And so I think having that kind of fresh mindset was a little bit of a breath of fresh air for them.
Yeah, without a doubt. I think in 2013, 2012, I was helping to convert a OBGYN office from paper to digital charts. So I would spend like 8 hours straight pulling charts, indexing everything, scanning their paper charts into I I don't even remember what the EMR system was at that time. But I was like all consumed with those tasks. So that
It
that
it was
those were
a it
crazy
was a
times.
brutal yeah, it was a brutal time. Like I think you and I have talked about COVID times before, but this was another like
Yes.
equally stressful, not equally, but very stressful time for healthcare workers. And if you are like me, it wasn't just one healthcare EHR that you kind of had to learn and adapt to. It was a trial by fire, like what's working, what's not working. So I've probably done, I feel like every EHR system that's out there at this point,
Yeah,
including things like the VA's PCRS and a last word that most people probably have never even heard of. But yeah, it's you kind of just learn to kind of roll with the punches, I guess, when you work in healthcare.
definitely. Definitely. Okay, so you join the new CDI ward at this small hospital, your foot on the door on day one. Tell me, like, what did you learn about CDI? Can you kind of educate the listeners a little bit about what it really means for practice, right? I'm sure that all of us can appreciate that the way that you code and the accuracy that you code in relation to the rules that are set, of course, affect reimbursement. But a lot of us in the inpatient setting or even in the outpatient setting, if we're not working at a small practice, we never really, number one, feel the impact of that. Number two, have a lot of visibility into what that really means day to day. So I'd love for you to explain a little bit more about why CDI is important, what is it, and the things that you learned in that role.
Yeah, that's a great question. I think one of the things that is pretty much standard if you're a nurse, if you're a doctor, if you're a PA, if you're anybody in the healthcare field is we don't learn about CDI and really learn about documentation other than on the job training. So my exposure to CDI quickly helped me understand that our documentation, everything in that medical record, the way it gets reported to not just financial reporting, but government reporting is through these alphanumeric codes. And so, like you were saying, you have a medical record, you have a condition, and then you have to follow a very specific way to index that medical terminology to make sure that it goes to the code and you have rules to follow. So, one great example that a lot of us give and is not so much a problem now because most providers have kind of learned at this point, but urosepsis. When I was an ICU nurse, I knew exactly what that meant. It meant a patient who was septic from UTI and was critically ill. However, the way that code is indexed in coding rules turns into just a plain UTI, sepsis of the bladder, not a systemic sepsis due to a urinary source. So those are some of the nuances and where some of the translation that we know clinically, and when I'm talking to you or if I'm talking to another healthcare provider, understand what I'm saying, but because of the coding rules, it doesn't necessarily always get translated into the correct and accurate clinical truth of what the provider intended. And since coders don't give direct care and they can't infer due to their rules, and providers aren't trained in coding, CDI kind of came in the middle to be somebody who is both clinician and also coding to try to bridge that gap. And so that has what started out on making sure it's accurate translations, also looked into missed opportunities if there were conditions that we were treating and investing our resources into and then subsequently not being reimbursed, or a patient looking pretty well on paper and then dying, to make sure that that patient's accurately reflected in the code set so it's true, their risk of mortality and how sick they were, how severe their illness was. So that is really in a nutshell what CDI does. But it's truly evolving every year, and the ways that we look at CDI. Now it's also clinical validation. So not just you diagnosed sepsis and you linked it to the urinary source, but did they really have sepsis? Were they
Sure.
really systemically ill? Does your documentation as a whole in your physical exam, review of systems, and history of present illness really support that patient being systemically ill? I've seen in working in denials as a part of my CDI job, I saw patients who on paper were probably very, well, not on paper, but in real life were probably very objectively ill. But on paper, they had a physical exam that looked like you or me. And so insurance companies, auditors, those people see those opportunities or see those deficiencies is a better word, not
Sure.
an opportunity, and they have to question it. Should we actually have to pay for this if they weren't sick, if they were, well appearing and
Yep.
in no acute distress? So that's kind of where CDI has been and where it kind of stands now. But as you can expect, it's going to just continue to grow and evolve, especially with advancing technology.
Yeah. So it sounds like CDI in a nutshell, if I were to try to wrap it up, it is not only ensuring that the codes, ICD-10 codes, CPT codes, etc., are being attached to the visit in an accurate way that describes the level of complexity in an accurate way for appropriate reimbursement, but then it's also being used so that we are able to maybe proactively identify patients or retrospectively, reflect on patients who may have had good outcomes, may have had bad outcomes, so that we can learn in the future what patterns there are, what things that we might be missing, to, of course, hopefully give better patient care. Would you consider that an accurate summary?
Absolutely. But I would say the caveat is that, when there are issues in quality reporting, those are all based on coding, just like you're getting at. They're all based on the things that are coded. But there's often a reaction, and I would say it's not necessarily the right one that we question. Did we actually code this right? Did CDI do their job? Did the doctors document it right? Because we can't actually be performing this poorly or have this bad outcome. But with advanced CDI, really earlier, the better, more proactive approaches into our documentation, we can really trust those codes to actually help us inform better care for the patients. So it's idyllic. I wouldn't say it's exactly where we've arrived yet necessarily.
That's fair enough. Fair enough. I mean, listen, I love me a macro, and we all know that as human beings, those macros certainly 10 times out of 10 don't get adjusted to reflect exactly objectively what is going on with the patient. So I
Oh,
agree, we definitely
100%.
have a long time to go.
We've
If
tried, but
Yeah. If my understanding is correct, CDI training is also a formalized institution.
yeah. There is often on-the-job training. How I learned it was through essentially a boot camp by Actis, and then through on-the-job actual working it and going through different consultants and having different ongoing continuing education that is provided. As CDI has kind of grown, now there are more of the introduction to people who aren't even in CDI now that are available through places like HC Pro and different online free resources, and a lot of key opinion leaders in the organization on LinkedIn give free education just by following them and reading their posts. So
Yeah,
it's kind of a hybrid of how you learn CDI essentially.
fair enough. Yeah, foundational learning, ongoing learning definitely look very different.
Yes, definitely.
So you transitioned to that role completely, like left bedside nursing completely, right?
Yeah, I did work like PRN a little bit,
Yeah.
but it wasn't really sustainable because of the hours of CDI are typically 40 hours a week. It's a full-time role. Some
Hmm.
places do part-time. There's few places that also do PRN on case-by-case basis, but for the most part, it's a 40-hour-a-week job because it requires continuous follow-up. You do a review, you need to see it the next day. You put a query in, you need to see it the next day. So working 40 hours a week, 9 to 5, and then working additional 12-hour shifts or 4-hour shifts if I was lucky enough to sign up for that just wasn't really sustainable. So I did leave completely in probably 2012 and focused solely on CDI. I did do a brief stint in case management to learn utilization management for about 4 or 5 years.
Hmm.
Um, Once I kind of got into CDI, I recognized that it was like an onion. Like you learn a lot about CDI, and then it's not just about like one of the questions you have to ask in coding is what was the principal diagnosis? Because that diagnosis, what was responsible for occasioning the admission is what drives the whole DRG that patient's grouped to. That
Yep.
we decide this patient had pneumonia, we're getting paid for pneumonia. Um, the more important question kind of became, well, what actually necessitated admission? You can have conditions like pneumonia and get treated outpatient in the doctor's office. So, what was the actual problem that presented and required that patient to stay? And that's where I learned I needed to learn about so,
Yeah.
that's kind of how I ended up in that role for the time I did.
Talk to me about the differences between and case management compared to CDI.
For my roles initially, CDI is solely looking at the code set, essentially. is looking at, are we actually even going to get paid for the visit? Is this visit medically appropriate? Should this visit been done in a less acute setting like observation, or should it have not even come into the hospital and not even stayed overnight? So those questions are a bit holistic. CDI traditionally only looks at inpatient admissions too. So I don't get to see in that CDI role those patients who are usually less severely ill and not necessarily staying. But in utilization management, we saw every admission that came in the door. And then some organizations still do this. We did not, or we moved away from it at the hospital system I was at, but we did case management as well into utilization management, which was a lot of discharge planning, like trying to figure out how can I get this patient out of the hospital in the best time frame
Yeah.
and with the right level of care. Like, should they go to a nursing home? Can they go home with home health? Do they not need anything? Do they need IV antibiotics? So that was another layer to the whole patient experience that I learned as well.
Those are really hard questions to answer.
Yeah, they are.
Yeah.
However, they're great foundations in both CDI when I'm writing my notes, and then utilization management should my patient leave when I'm dealing with patients in my NP role. So
Yep.
it was a really great foundation, at least for that, I can say.
You
But
are not a hard sell for a private practice, girl. Like, you know exactly what to do.
Yeah. When I work in direct care, it's sniff. So
Okay.
those questions come up
Oh
all
my
of the
gosh.
time.
Yes.
Like, my patient here needs labs. I need to get them done. Stat labs in the ER, come in minutes, or, if you have an iStat machine, maybe less, or, hours. For me, it means 8 hours. Like, so I have to decide, I think this patient's got kidney failure. They've not been peeing. Can I wait 8 hours to see what their creatinine is, or do I need to send them out? That
Yeah.
sort of thing. A lot of
Yeah.
judgment calls, but it helps to kind of have that perspective of what we can actually do versus what actually can't be done in that setting. So
Absolutely. Yeah, and I think with any clinical role, you learn what
you do.
the constraints of your individual setting are.
Yeah.
And you develop the ability to like reflexively know what to do.
You do. You do.
Yeah.
But it's all like, no matter what the job is, if it's utilization management or CDI or clinically, so much of what you learn is on the job through experience and trial and failure. So,
Yep.
you kind of end up, taking that experience and then hopefully growing from it.
Yeah, I totally agree. So you now have alluded a little bit to how your clinical journey was not over, when you thought it was going to be.
Yeah.
What happened?
So after spending time in utilization management, it's such a long story. I feel like to tell why I'm at where I'm at, it's a very complicated and long story. So, but essentially, after I spent time in utilization management, I was really craving that autonomy that I had back in CDI, and I thought I could do the job better now. So when the opportunity came back to go back to Kettering, where I was at, and relearn CDI, because so much changes in that time that you're not doing it, I jumped at it, and I did it for a few years. And got to the point where I felt like, I'm an experienced nurse. I've been doing nursing since 2008. I've done direct care. I've tried all these different roles. But the one thing I haven't ever experienced is the pain of the provider. And I can send queries and they can tell me no, and I can be mad that I was wrong, or I can try to learn what their perspective is and why they said no. How do you get a history? It's easy for me to judge your documentation when you're the
Sure.
one who put it all on the chart and had to gather it and start from scratch. So I really felt this drive and desire to go back to school and become an NP. And then I did that, and then COVID happened. So I
Tale as old as
graduated.
time.
Yes, graduated right in the middle of it. So
Yeah.
that
We
was
probably
so
graduated
much
NP
fun.
and PA school right around the same time.
Yeah, it was not the
Yeah.
best learning
This is
environment, but
really
honestly,
not.
it was, I feel like it was just a different way we had to learn. So,
Yes. Yeah, really, really hard.
Yeah.
So I love that like that decision to go back to school was driven by curiosity and almost you gave off a sense of like competitive excitement when you said that. It's like, yeah, like I think I want to push myself a little bit harder. I think I can go further. I think that like I can do more and I can do it really well because obviously you laid the bricks to be able to have a super solid foundation. And deciding to go back to nurse practitioner school, I agree, sounds like a very reasonable next step if the healthcare system didn't already like destroy you, which thankfully, you took the preventative measures to step back a little bit and, try something different. So you get
Yeah.
out of NP school, it's the middle of COVID. Do you run right into a provider role?
I tried. I don't know if you experienced this at all, but because of, not having experience and there was a pause on a lot of APP hiring in my region,
Yep.
it was extremely difficult to find a role as a provider. So I still kept my CDI role, and
Okay.
that was like a canon event, I would say, in making me where I am at today. I would say if I had had it my way, I would have gone directly into a role 40 hours a week and just been done with CDI and learned this new experience, just like I've done with the rest of my career. But because I did not have the opportunity to get a job right away, I was able, and my organization was able to see what a benefit it was to have an APP working with their CDI team, with their team, with their physician advisors to help kind of bridge a lot of the silos and gaps that we have in these systems already that are just part of the job because it's all independent goals, independent outcomes that we're looking at. And as our physician advisors became more developed and having good outcomes, they get asked to do more things. So having another person who was not the cost of a physician was a real helpful benefit for the organization in terms of fighting denials, working on education for more peer level discussion, and so I did that, but I was able in that meantime in that period of time to find a role in direct care as well. So I could actually put my provider hat into practice, working with a provider in the post acute setting, which I'm still with her. I
Hmm.
just don't do as many hours as I was. And, learning how to practice outside of my skill set in a lot of ways during COVID helped me grow and adapt as well.
Right. What were some of the biggest things that changed after you became a nurse practitioner in relation to CDI?
Oh, wow. I would say my perspective completely shifted
Okay.
because A, I know the burden of documentation, the pain points of documentation. I have to deal with the issue. I had to deal with the issues of documenting hours in the evening, even after I had seen all of my patients and gotten all of my orders in and done all of the hands on work. I was sitting there charting forever.
Yep.
And I could understand why I might not get every single diagnosis correct. And I was the one who was responsible for documenting a very thorough history of presenting illness to really give all of the clues for those CDI nurses to be reviewing. In the post acute setting, we have MDS nurses who kind of it's a different type of payment model system, but they do a lot of the same type of outcome measurements, care. Care guidance and documentation support. So it was a completely different perspective, but gave me an appreciation for the in-basket burden, the documentation burden, the pajama time, all of the things that I got frustrated with on the CDI time. Why is it taking so long for them to answer my query? I got to
Yep.
feel it on the other side. So
Hmm.
I feel like it's made me more well-rounded in my views in CDI to do it all. And I think if you talk
Certainly.
to a lot of the physician advisors who are into CDI as well, they would say the same thing.
Yeah, there's no doubt about that. We've certainly all on the provider side and on the nursing side as well, felt the huge burden that is documentation. It is so challenging. Not only like you said before, right, to give your 1000% of yourself
Yeah,
every single day in communication and active listening and empathy and brain power to try and help this person to the best of your ability, and education for them as well about whatever path we're gonna go down. And then also come back and like, okay, the conversation is over. Now, how much time do I have to get as much of my brain out onto this paper in this very structured way before I'm getting pulled in another direction or have to go and see another patient or somebody calls, the pharmacy calls because I didn't send the right kind of eye drops or their insurance denied Dex. Can we change it
absolutely.
to something else? There is so much of a barrier to sustainable, high quality care when it comes to traditional documentation. So that's really interesting that you
Yeah,
were like,
absolutely.
"Oh, I get it now."
Yeah, I do get it. And to your point, personal life too. Like, how
Yeah,
do I recharge at the end of the day when I'm mentally fatigued, emotionally fatigued, and I'm really decision fatigued? Like, now I've got to spend that documenting and trying to get everything that I just gave my soul to out on paper and sacrificing the time for me, the
right.
time with my family or with my pet or just doing things that aren't healthcare. I think it's precious time that you absolutely need so you can give good quality care.
Yeah, without a doubt. Did you so you stayed working with CDI as a nurse practitioner for a while?
I did, and we ended
Okay.
up leveraging that role, while I was working pretty much, half and half, a little bit more on the direct care side than in CDI. We ended up leveraging that role into an actual formal position with Kettering, where we were able to see actual tangible outcomes from my, work in first starting with denial appeals. So it's not just the medical necessity denials, like your patient didn't really need to be at the hospital. More and more hospital systems are seeing denials based on the diagnoses, like they didn't really have sepsis or respiratory failure, kind of what I was inferring. We saw
Right.
a lot of good outcomes and higher appeal rates, higher overturn rates once we were able to invest a clinician in that process, and have me help triage some of the denials that came. Like, I'm not going to be the best person to defend an OB denial necessarily, but we have an OB physician advisor who is able to help support and appeal a lot of those cases that came across. So, it ended up being very beneficial for denials, but then we could see that it was very helpful on some of the more complicated CDI topics that have happened, evidence updates, and then we have to then educate, or the evidence updates, then codes update, and then we have to educate providers who may not be up to date in practice with terminology. So, non ischemic myocardial injury is a term that came about in 2018 with the updated cardiology guidelines, but um, and the fourth universal definition of an MI. But a lot of providers were still using outdated terminology that was describing like demand ischemia for a non ischemic event. But they're with myocardial injury. So that's not common practice. It created a lot of controversy when our CDI nurses tried to educate on it. So having a provider then provide the education for that was helpful. And
Sure.
then I also helped out with our sepsis steering committee, as we were trying to define sepsis both clinically and in the coding world, helping us make sure that we're accurately reflecting the patients from both the quality core measure perspective, but also the actual patient outcomes and the coding perspective. So there was growing need for that clinician support that really understood all of the different nuances, and so that's how we kind of created that role.
Sounds like it evolved really naturally and definitely not effortlessly, but in a way that was harmonious maybe,
It
and,
was. It
like,
was filling a lot of needs.
allowed you to give them support that ended up being really crucial, allowed you to also expand your knowledge base and expand your, like, depth of understanding as far as CDI goes, and I'm sure that it made you a better provider as well.
I think so, and especially when you have to go toe to toe with another provider challenging
Yeah.
your thoughts or your interpretation of literature. I think that is a really great growth opportunity.
Yeah.
But it definitely shaped a lot of my perspectives and opinions that I have, today.
Thanks for sharing all that. That is a windy, windy journey, but I know that
I
the
know.
journey is not done.
No, it's not.
No, it's not. Strap
It
in.
keep just keeps going.
So, what's
Uh,
next? I would assume that, maybe if you're a normal person, if you are, okay with sticking with whatever society expects from you to say, I'm done. This is where I'm going to be for the rest of my life, that you would maybe have your hands in both pots. You would keep practicing clinically, keep doing CDI, but no, you experienced yet another evolution in your career journey, and now are really advancing in your career, I think, in a way that I don't know if you expect it or not, but is hugely, hugely impactful, like nationwide impactful. So I'd really love to learn more about how that evolved, how that presented itself, and I want to kind of get into the nitty gritty of what that job has looked like for you.
Yeah, well, as you kind of alluded to, I've just not been a person who feels like, "Oh, okay, I've landed. This is where I'm gonna stay." I'm just a
Yeah.
person that kind of continues to find challenge and growth and development, and, I ended up going to conferences, national conferences for my healthcare organization and really got inundated with this new thing called AI. And I know you've seen it too, and I know you've been kind of uh, exposed in the similar ways that I have, but it makes you ask a question. What does this mean? How is it gonna help my organization? And what's the best use? Because everybody now that's a hot word is calling themselves AI. So after that conference, I really started to do my digging into the different companies that were out there, the different technologies that were out there, different solutions that were out there. And I gradually, through all that learning, developed my own thesis and hypothesis of what I thought the ideal solution is for specific to revenue cycle and documentation. And as CDI is evolving towards less retroactive work and a desire for more proactive approaches to documentation, so stop asking things after the fact and get on top of it from the beginning, I felt like there was a need for AI use that was CDI focused at the point of care. And that's where I met Ambience, the company that I work for now, and talked with their product team and talked with the founders and really understood that that was their passion, was not just money chasing, which is historically what CDI has been given the reputation of. They were wanting a product that was actually CDI informed, that wasn't going to create denial problems downstream, and that was ultimately clinical truth for patient outcomes. And since that really matched my soul, my husband for years had always been telling me, "You work in healthcare, go do sales, go do this, go work for pharma." And it wasn't where my passion was. My passion
Yeah.
was to influence an industry. And I feel like you kind of, like you alluded to as well, that doing this type of work, working in product for an AI company, can impact patients, that thousands of patients, tens of thousands of patients, hundreds of thousands of patients, hopefully millions of patients through more industry wide change. So that's exactly why I landed there.
Well, healthcare has traditionally certainly not been proactive, at least the way that we have known it. It is a
Yes.
very reactive industry, not only to, like you said, coding, billing, documentation, claims, but also patient care. And I think that is, in my opinion, one of the best potential outcomes for the use and utilization of AI tools is to make it more proactive, whether that means we're able to look back in a patient's chart and give the provider like a summary before they walk in the room, better than the best MA or the best triage nurse ever could, and really flag things that could truly change the course of the patient's illness and disease without oversight. Additionally, allowing documentation to be more streamlined, documentation to be more complete and more accurate and more compliant. While the other, I think, beautiful truth about AI is that when we integrate the ambient listening tools, you can't make things up. So it
Yes.
is truth. It is honest truth of what did this encounter encapsulate. You can't, you know, I'm assuming, I hope, you can't write lines into a transcript that gets attached as evidence for a code, right? So it is really ensuring that not only we are giving, the most accurate coding and documentation for these patients, but also that we're holding providers to a standard of like, hey, like we're putting the rubber to the road. You need to be here. You need to be completely present and having these conversations that maybe you backed away from, but I'm sure some people, you document things that didn't happen. I'm sure that that's another part of CDI that you discovered as well. So where did that journey with ambience begin for you, and how has it changed over time?
It started in product, and it still is in product. I mostly serve as subject matter expert in that role. When I talk about product, I mean really, um, not just software and coding, but actually building that solution that works for, clinicians like you and me in the real world, but also helps uplift a lot of the burden and in-basket CDI, coding and all of that. So it really gives like it's more of like an intersection with that clinical insight and some of the technology design, like this looks good or that looks good, or this is not a good for the workflow of the clinician, but also the strategy and of the operation and what we develop too. So
Okay.
it's kind of, I guess I would say, translational work. And CDI is very similar. You're translating clinical scenarios into codes. This is very similar. It's translating kind of those clinical pain points and the CDI pain points into something that can actually be built and then teach them that language. It's challenging because in CDI, I don't have to worry about the healthcare translation because you know what I'm talking about in the healthcare world. But when I'm having to then translate it to software people who aren't
Sure.
medical, there's almost a double layer of translation that kind of happens. But I don't say so. I'm not like I would say a coder. I'm not like in the met or in the terminal like software coding, but I really do like help co-create, help guide the product leaders to the right solutions and make sure that our voices are heard in that experience.
Is
But over time the roles kind of evolved
Yeah, a common
past product.
theme with all of the guests that I've talked to has been that number one, if you took their role and you put it at a different company, it's a completely and totally different job description, period. Number two, even within their role where they have landed, the role is different week to week. So
Yeah.
there's a difficulty in really narrowing it down. Um, did you find that there was more of a single role in your past that has led a lot of your work now with ambience, or do you feel like it is really the combination of all of them together?
Definitely a combination of everything, because the solutions need to serve both, nursing, both the provider, CDI, so very much collaboratively. But I would say first and foremost is probably definitely that CDI experience and the provider
Right.
role. The hybrid of those two things have really influenced a lot of the decisions that I've made and a lot of in not just my career choices, but within the company itself and the development of our product, as well as some of our strategy when it comes to sales and the way we talk with customers and the feedback we get from customers. So I would say probably those two roles are the most influential in where I'm with things today.
Yeah, makes sense. Is there anything in your time with ambience that you remember recognizing, like, that is not going to work in the real world? Can you give some
Uh,
visibility to what that has been
yeah,
like?
Absolutely. I think minor suggestions. Overall, I feel like the strategy has been right and I can help guide that strategy. But some of the solutions that are offered are done so in a way that I'm like, well, that would never work for a provider. For example, if the click miles that we have to have as a provider, less is more. You're not going to get patient. You might have a really great product, but are your providers actually going to be using it if
Yeah.
they have to click it? And if they're not using it, then it's not a solution for CDI and coding either. It's not a solution for documentation. It's not a worthy investment for an organization. So, reducing that effort, reducing edits, like some of those solutions that I've seen give a good baseline product, but does it really end up saving you time if you have to make a million edits and tweak things? So I think those are a lot of the ways that I help safeguard the product and make sure that it's actually a solution that is helpful to providers and not adding to their workload or their cognitive burden.
Click fatigue is real as well. And all those things just contribute to burnout and yeah. So, talk to me about the difference in the real world between retrospective CDI and proactive real-time CDI. Like in a tangible sense on the receiving end of the product, what does that look like and feel like?
So I would say retroactive is cleaning up a mess that shouldn't have occurred in the first place. It's also you're also losing a lot of the benefit of that direct care time. So one, when the patient is freshest in the provider's mind, CDI send queries. Typically, what our process was is you won't get an H&P the very minute a patient arrives. So we would do it the next day and we'd review the ED note and the H&P and whatever other notes we had, and then we'd send a query. Well, that might be a different provider. It might be a
Yeah.
different, it might be that patient might be one of 20 that provider had, and they might forget exactly how that patient presented. So if I'm looking after the fact and asking, did this patient have sepsis? They had X, Y, and Z going on. They seem like they're more sick than just a regular infection. The provider's not going to necessarily have the benefit of that fresh mindset on that patient, that fresh eyes, when they've already slept on it and moved on to the next patient. So the other impact is in getting the charts out and getting those codes reimbursed in a timely manner, because healthcare in general, we are investing resources and then praying and hoping we get our money back on it. We don't have the benefit of deciding after the fact if we're going to treat something or do something. We have to make our best judgment call and invest those resources right then.
Yep.
And so anything that can eliminate administrative burden or throughput burden for the patient or even the bill or the chart, or getting those codes to claim and getting those codes out for reporting and for research, needs to be moved earlier in the phase of things. So I think that's where CDI wants to go as an industry. From all of the leaders that I've talked to, they want to be able to inform and make changes. I'm still sending queries in CDI that I sent for acute and chronic CHF, what's the type. I'm still sending those same queries in 2025 that I sent in 2011. So what we are doing, and we haven't been able to move ourselves as less of the financial productivity, like ask a query, get a response, take your credit, say I made money for the organization or saved money for the organization. And now we're making ourselves more a part of this, a cemented part of the care team, being there to ensure that the documentation is quality, that the things that are documented actually happened and the treatment was actually given to the patient, and
Yeah.
being more of a check and balance for the provider as well as educator, so that we're not spending so much time chasing these low-hanging fruit. We're actually able to spend more time in collaboration and education. And then I think the final part is a reputational repair. CDI have had to ask stupid queries because of stupid coding rules that we can't change or impact. And so that has created some distrust between providers and CDI nurses. And so removing those stupid queries, as I would love to call them, and allowing those nurses to practice at a higher skill set, allowing the coders to practice at the higher skill set, really helps repair a lot of that reputational and relationship damage that's kind of happened because of the nature of what black and white coding rules have to do to patients who are never black and
Right.
white.
Wow.
So.
Those are huge improvements and huge changes. Was there such a focus before on did this really happen, or is that sort of a novel approach
I
and
think
problem?
it's yeah, I think it started with us just asking the question, is there CCs or MCCs? Are we treating something and something there that we aren't documenting? And then with the evolution and reliance on our reimbursement system and more and more payers over time going to MS-DRG or APRN reimbursement, they started to say, well, did it really happen? And because of that, and because of auditors and like RAC and MAC and and the government actually saying, hey, if you submit this and it didn't happen, that's technically a false claim. And that's waste, fraud, and abuse. It's illegal. It goes beyond reimbursement. It's
Huh.
DOJ stuff. So between that and then a lot of the Med Advantage plans getting audited by OIG, it's
Yeah.
just caused a lot of organizations, a lot of providers to reflect on the meaningfulness of their documentation and ensure that that truly did happen um, with the patient and reflecting their true story.
Yeah, I
Yeah.
mean, I think like I said before, the one really fantastic thing is that the ability to reflect on a transcription gives us much better information on what really happened. And I think also like gives
Yeah.
more opportunities for learning, right? Because you can actually draw from the true experience, the ground truth, what happened, um, and interject with feedback, whether it's positive or critical or, somewhere in between. And
Yeah.
ultimately, I
And
think a lot of us agree that like the goal really is to make sure that we're treating people to our best and highest capacity. Um,
yeah. And there's ethical guidance that we have from that as providers. But there is like industry guidance too when you talk about compliance from the Aptus and AHEMA, the regulating bodies for CDI and coding that say you can't tell a provider what to write. You can't lead them. You have to tell the truth. Your queries and the interventions that you do need to support the truth. And
right.
so having that discoverability of a transcript and that bias removal of taking a human out of it and allowing the provider to be in control of the codes that are selected and the terminology used really helps make sure that the solutions are being led by humans. They're utilized as augmenting, I think, a lot of the things that we do and the requirements that we have, but all being overseen by, advanced human knowledge and reasoning.
Yeah. What have you noticed through providers that you've talked to who have had the pleasure of using the software? What are some of the feedback that you get from them?
Yeah. Well, I get to use it when I
No
round.
way.
Yeah.
Oh
So
my
I
gosh.
I get to feel the benefits of it as well. I think a reduction in their charting time and their time in the EHR is significant
Yeah,
and reduces burnout. But also the way that it's used and the processes to get the chart completed are very friendly to the provider and help reduce the whole time in the chart because we're not having to go back and fix things after the
right.
fact or even during the note itself.
Yep.
I think one thing that I love about the tool, well, I'll say two things. One is that when you work with patients who have been hospitalized, they have a lot of my patients have cognitive issues. I get a history, they conflict themselves.
Sure.
It's not just a lot of times you see a provider's note conflict itself just because the patient conflicts in the history so many times. And so when they change their mind in the middle of the conversation and decide, oh, wait, no, I actually didn't have that issue, this helps remove a lot of those conflicting things that happen during the history time. So I love that. And then the other thing it does extremely well at is accents and patients that may have expressive aphasia issues. Sometimes I'm sitting there and I'm like, I really don't know what they said. And so the technology really can account for a lot of that. And helping me decipher what was actually said. And I'm like, oh, that makes sense. That's why they were saying this, because they said this. And then finally, interruptions. Like when you work in healthcare in the office setting, it's nice. You don't have as many interruptions. But I have nurses pop in my room and be like, hey, this other patient has XYZ going on. And that doesn't pull into my note. It completely removes it and realizes that it's talking about context from a different clinical situation.
Yeah.
And so I don't have to worry about all of that issues. And then I guess one other thing too, I keep thinking of situations as I talk, is like sarcasm and quotes. Like patients are very
For sure.
they don't say I have vertigo or dizziness. Sometimes they do. They might be like, I feel woozy, and it quotes the patients in the ways that I would quote the patient. So those are all things that help make it more of a usable product. And feedback that is consistent with what I've talked with other providers for.
Those are not the benefits that I expected you to touch on,
Yeah.
and they make so much sense to like improving your experience of interacting with people, interacting with the EMR, interacting just as a provider and a clinician in general. So great insight. Thanks for sharing those.
What would you expect
I
me
think I
to have
expected
said?
you to say, well, you touched a little bit on the time in the EMR. Obviously, I think that
Yeah.
that's a really low hanging fruit. I think just the act of typing a note or the act of like my current workflow is for anything beyond a pretty uncomplicated patient. I use a scribe, I pull it up, I have my phone, I speak into my phone, then I have that up on my computer and I refresh the page and I have to copy the note and then I have to find my note in my EMR, open a note, find where I want to put it, paste it, make sure that it all looks good. And then I haven't done my physical exam. I haven't done my
Yeah.
MDM. I haven't put the diagnosis in. I haven't put my orders in. So it's just one part of a massive conglomeration of steps and clicks, and making sure that each part complements each other, and making
Yeah.
sure, just like you said, if I forget to click um, ill appearing on a patient who I've sent to the ER, then that's going to be a problem,
Yeah.
which is really easy to have oversight there when you are, inundated with tasks. I think I also expected you to say something about like after hours charting. But I
Yeah.
think that maybe those things are just such low hanging fruit. And once you are able to use a software that has so many benefits, you really realize what were your true pain points beyond surface level, and
Yeah.
how does it really complement you?
Yeah, I think that's a really good point because there's so many AI scribe vendors that are out there. A lot of those bigger topics are things that they all claim to do. And the differentiators for me have really been in the things that I kind of talked about and have the providers have talked about. Why we typically are the clinician's first choice is because of those bit, seemingly small nuances, but cumulatively huge. And integration, like you're referencing, huge. Like it is a pain in the butt to have to copy paste things. So
Yeah,
one less step, one less click mile for you to just be able to either use Haiku if you're used to it or whatever, or use a native app and have it already be integrated into the EMR itself. Um, Such a time saver.
right.
But yeah, you're you hit on a lot of the big ones that people
Yeah,
talk about with AI scribes.
yeah. Where do you think this will evolve in the next 5, 10 years?
There's a lot. I think as much as we have focused as an organization in the impacts, not just improving the life of the clinician, but improving the life of revenue cycle team, improving the truth and the note quality to the patient and patient instructions that are actually meaningful. Like these things are all great focus and great foundation, but I think there needs to be continuous evolution. One, in coding guidance integration and making things a little bit more hands on for a provider in terms of something that they don't need to be educated and shouldn't be educated on, but also a movement towards utilization management, meaningful documentation. Why is the patient here and why do they still need to be here? Why is this patient need to be here as compared to somebody else? And why does this patient, as compared to another patient with a similar problem, still need to be here? And hopefully that can have health system impacts in reducing avoidable days that patients are in the hospital setting, reducing the risk of patients acquiring hospital related infections or issues like blood clots and that sort of thing. So I'm hoping these kind of movements and developments and plans in our roadmaps will help then um, inform patient outcomes and improve patient outcomes as a whole. Like we probably already are. We already have these solutions, but I just think there needs to be continuous evolution and development. That's just my perspective. Can't speak for ambience as a whole. Honestly, I think there's always so much changing when you talk to AI companies and vendors and people that sometimes your priorities have to shift very, very rapidly.
Absolutely.
But that's kind of where I would hope for the future of AI technology to go with healthcare. More impact and more meaningful impact for patients.
Yeah, I think that that is also where I see things headed. I've never once had the thought that AI or any sort of technology advances would replace providers. Like never, ever, ever once. However, I think it has the potential to make us so much better um, than we have been like ever before.
Absolutely. I think people who have gotten into AI solutions in in their practice clinically have really kind of come to have that acceptance and understanding. I'll admit, like my first initial thought was, is this going to replace me? But I've learned through one, working with the company, but also using the product exactly how it can help me be a better provider
Yeah.
and using other AI products too. Can help you really practice to the top of your skill set and spend less time on so much of the redundant work that we have just become accustomed to. We forget how much time waste we have
Yep.
because it's just reflexive for us at this point.
I know. I have such a deep admiration for providers who really do practice at the top of their scope up to this point, where we really haven't been empowered with tools to truly make our lives easier, yet
Yes.
continue to, like, stomp through the trenches every single day and get it all done and give their patients like such high quality care. It's extremely admirable to me, and I'm also feeling so excited for those people to have access to tools that will maybe let them develop a deeper relationship with their family, let them develop a deeper relationship with themselves outside of work, whatever that looks like for them. I think that there is a lot of really good on the horizon, and that is a blanket statement because it is so loaded and it's so multifaceted. Um, so I'm really excited for what is to come for sure.
Yeah, me too.
So if you were to speak directly to anyone with a nursing degree or even who is like an APP, and give them some sort of insight into if they're exploring a career change, if they are curious about CDI, if they have no idea what they want to do and just are wanting to kind of poke their head around, what are some things that you would encourage them to do?
I think exploring and learning and networking are really great, tangible ways to learn the space of CDI and AI and utilization management and nursing in general. But this isn't necessarily what I'm doing right now or what I did in CDI isn't going to be something that everybody loves. I think you have to be very comfortable with change, which can be hard for some people, and ambiguity. There's a lot of ambiguity, and also partnering. It's easy to just kind of be authoritative and know the solutions, but you have to be able to influence without that. And then also working at paces that are really faster than what we're used to in healthcare. It's usually there's a lot of change resistance in healthcare, and just trying to have
Yeah.
pull people along. You have
Oh,
to be
yeah.
patient for that. But I feel like if you love problem solving, and that's great for CDI. It's great for moving to a healthcare tech type of role, but also like working cross-functionally, learning a completely new industry, and really trying to drive that change resistance, but drive change at scale. I think that's incredibly rewarding. And I would just say it's not the place to escape burnout. I would say you would really have to move into some spaces like these because you want to shape um, the future of healthcare.
That is great insight, great advice. Thanks for sharing that.
Yeah. Do you want me to ask? Can I ask you a question
Of
with the
course.
time we have left?
Yeah.
I guess I kind of would love to hear from you and your perspective on what you think healthcare tech companies, um, how they should be reaching out and being informed by clinicians, and if there was one specific way you feel solutions need to address. I'd love to hear your perspective.
Okay. Thanks for asking.
Sorry for throwing you off like that. I'm
No,
going.
it's okay. I think I'll start with the problem that I see, and then I'll follow up with how to reach out.
Okay.
So to be totally honest with you, Erin, the one thing that I feel like is actually lacking is just clinician collaboration. Um, my personal pain point is Ambience's mission. So my personal pain point is truly documentation and coding. Um, I have worked urgent care and ER, and I've never been empowered or augmented with tools to help with the administrative burden that comes with those things. Um, I I joke with my coworkers all the time because like I'm a human being, right? I try to keep myself on task, but my job is to be dynamic and to be um uh, uh, essentially like available for yesterday I saw like 43 patients by myself in a 12-hour shift. I also have the expectation and the professional responsibility to close those charts. I always set the expectation for myself by the end of the day. I'm not somebody who takes work home with me. I tried that for like a month and I'm like, I can never do this again. This is terrible. Like you said, I don't remember my patients. I don't remember the nuance. I don't remember the details of the conversation that we talked about. And sometimes in those settings, those interactions really blend together. And without like, I don't have a, visual identifier. Most patient charts don't have a picture of them in it. And to go based off of their name and the sometimes very vague triage note, it's really hard to bring back the nuance into a note retroactively. So, um, for me, that true, honest pain point is actually the real time documentation and helping me capture the complexity of each patient. Now, as a tech savvy person, right? Like I've told you how I've implemented changes in my workflow. Like I have macros for pretty much every common chief complaint in the urgent care setting. And the things that I know are pertinent positives, pertinent negatives, things that I build into every single discussion with a patient that I would have for each complaint. But without the comprehensive integrated tool, I know because I'm a human being that I'm still missing steps. Um, there's a really funny thing where I was talking about this with my coworker yesterday. My poor x-ray tech. I am so bad at walking out of a patient's room, identifying, hey, we need to get an x-ray on this person. I sit down, I type their diagnosis in, I start their note, and I'll write like little details about their case. And then I tell my x-ray tech, hey, I need a left wrist in room 2. And I never put the order in. And I'm like,
Yes, orders.
oh my gosh. How many times am I forgetting to put orders in? There have been
Yeah.
like, I'm a human being, right? I have not sent so many medications, and the pharmacy calls me and like, hey, Joe Schmo is here. He said that you were going to send him an eye drop. I'm like, I thought I did. Or this, UTI patient, you had a conversation with them. She was expecting diflucan. I'm like, she absolutely was. And guess what? I didn't put that in because in the time that I walked from the room to my desk, I was pulled in 3 different directions.
Yep.
So it's really challenging. So to be totally honest with you, that is the pain point that like I feel so passionately about. Number one, driving forward and evolving and thinking like you have about the nuances of how you've benefited from it in a SNF setting. Like what are the other benefits that could be realized that we might not be thinking about as the really low hanging fruits? And then furthermore, getting it actually into the hands of more providers. So that is something that I am extremely passionate about. It is part of the reason why I started this podcast, because I think like I want to have more of these conversations with people who are influencing these products. And my goal is to end up in a space where my voice is part of the pool as well, because it is not working the way that things are running at this point. And I want to help my coworkers. Like I love my coworkers. They're amazing. And I think they have such a huge capacity to be incredible providers. Like I am so lucky that I work at an organization where we really have a stellar team of people. I I have been in different settings. I remember like in rotations and previously like non-true professional like MA when I was working at the OBGYN office converting their office charts, and like I've worked in many different healthcare settings, and truly this organization is so special in that like we really have an A plus team. Um and they're getting burnt out, and
Yeah.
they're not showing up as their best selves, and patients feel it, and that sucks, point blank.
Yeah.
So
It
that's
does.
sort of my mission. um I wish that more companies were truly proactively having conversations with clinicians. I wish that there was more generalized outreach. Maybe that means specialty specific outreach. Maybe that means acuity level outreach, but with every person along the pipeline. So an MA's needs are different from a nurse's needs, are different from a rad tech's needs, are different from everyone else along the patient journey. And I wish that there was a proactive, generalized outreach, even if that is like for the task for like a UX UI consultant, someone who's
Yeah.
really good at like asking questions that get to a deeper level to really uncover the problem, but just something that feels like our voices are truly being taken into consideration. Because I think like the classic saying of like, oh well, you can tell when something was like designed or built by a woman, right? You can tell when something was designed or not with clinician oversight and clinician input. And the things that you've said about like click miles, when a product is deployed, that you just have this feeling of like, oh my gosh, it's actually so simple. You can tell that there was clinician oversight. And that's a really, really important thing. I think that that matters not only for adoption, but it also matters for retention and like ongoing satisfaction. And then you create advocates. Like you create people who are willing to organically spread the good news about this product. And that I think has exponential benefits, not only for clinician satisfaction, but also for level of care. And of course, that benefits the company as well.
Yeah, absolutely. I think that's like a great, like, red flag, I would say, if people are looking at, like, other companies or solutions, is somebody who doesn't listen to people or thinks or does it from a small sample size. Nothing in healthcare has improved with small sample sizes. The more voices that you include in your product, the more opinions that you gather, you're really able to find trends and identify opportunities for improvement and then future development. So I think that that's like a great plan for longevity for a company, and I think you hit the nail on the head with pinning that down.
Yeah.
Yeah.
Yeah, I get charged up about it when I start talking about it. So
I'm glad. I love
I'm
hearing it.
looking.
I think you have an opportunity, you have a platform right now. I think you should put it out there. So
Well, we will. We will
yeah.
push on.
Yeah.
Okay, so we are running out of time. Before we wrap up, I wanted to play a game with you,
Okay.
my documentation expert. We're
Uh-oh.
going to play a game. Is this ICD code real or fake?
Oh my gosh.
Rapid fire style.
Okay.
All right, are you ready to go?
Uh, yeah. I'll give my
What?
best gut. I'll give my best guesses.
You got it. I trust you. I fully believe in you. Okay.
Oh my god.
Number 1. V98.33XD sucked into jet engine. Subsequent encounter.
I think that's true.
It's
Is
true.
it? Oh, I was gonna say, I think I've heard that one. We have like a Slack channel where people send codes and like, I'm like, okay.
All right. Y93.D. Activities involved arts and handcrafts.
I don't know. I've not heard that one.
It's real.
False. It's real? Oh god. Thank God we can index that.
Yeah. Z99.89. Dependence on enabling machines and devices, not elsewhere classified.
I have to say that one's probably true.
Yeah.
Just because they're not elsewhere classified.
Yeah, exactly. Okay.
And Z codes are often dependents, so.
Yes. Y92.146. Swimming pool of prison as the place of occurrence of the external cause.
I feel like it's true.
It's true.
Oh my gosh.
W61.62XD. Struck by duck. Subsequent encounter.
Oh my god. It's true?
It's true. Great job. Here's the kicker. All of them were real.
Yeah, it's nuts.
This list also includes other contact with cow, subsequent encounter, burn due to water skis on fire,
Oh my gosh.
spacecraft collision injuring occupant, struck by macaw. Bizarre. Oh, I loved. I could
Is that a
definitely use this.
bird?
Yeah.
Okay.
I think I could use this.
I'm glad we're getting
R46.
specific on the breed of bird.
Yeah, they're so specific. R46.1 bizarre personal appearance. Where
Oh yeah.
That's a good one.
If you like all these, I think you're going to just love when ICD-11 comes out.
Right. Right. Yeah, it's a fun time. They're pretty crazy. I have a friend who runs a podcast where every single year around the holidays, she puts out like her favorite list of ICD-10 codes that are holiday related.
Oh my gosh. You're going to have to send me that. I would love
Yeah,
that.
I will. You can share it in your Slack channel.
I will.
For sure.
Awesome.
All right, Erin. Well, this conversation was excellent. I think, you did such a great job of explaining and giving us more insight onto what the differences between CDI and utilization review really means in practice and in theory, and how the perspective of a nurse is very, very different from the perspective of a nurse practitioner when it comes to both of those roles. How to continue to challenge yourself and refuse to, stay planted where you are and instead just continue to grow and evolve as a person. I think that shows a lot of, number one, just straight up curiosity, and two, resilience as a human being. I think it shines through that you genuinely care about helping others and really advancing the future of what healthcare looks like for our society. And I really commend you for that. It's been really fun to get to know you a little bit more and talk to you again. So thank you.
Yeah, thank you so much for having me. And I'm looking forward to continuing our conversations, and I'll make sure I share this everywhere.
Yeah. If the listeners want to get in touch with you at all, if they have any questions for you or just want to follow up or connect, where can they find you?
They can find me on LinkedIn. If you me up, it's just Erin Kreider, ERINKREIDER. And I've got a lot of letters after my last name. So
Perfect. I'll put that link in the show notes as well. If you want to find me, I'm Kayla Bassett on LinkedIn and it's.kla.b on Instagram. Those will be in the show notes as well. Thanks for tuning in to another episode of Corporate Espionage. If you are a clinician who sees yourselves in either of our stories and wants to share your story, please feel free to reach out. I would really love to talk to you and learn more about how you're pushing the boundaries of what is expected of people who wear our hats. Obviously, we both have a passion for, people who think a little bit differently. And I think that these conversations are so fun to have, number one, and so valuable to share.
awesome.
Cool. So please subscribe, give us 5 stars wherever you listen to podcasts, and stay tuned next week for another episode of Corporate Espionage. I will talk to you later, Erin. Thanks again.
Bye.